Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by our senior colleague, Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of Nath Arua and the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 391 of our pharmacotherapy series, which majors in seizure disorders. Our next clinical case reads, TDK, a 7-year-old, 25-kilogram girl, is reported by her teacher to have 3 or 4 episodes of staring daily. Each spell lasts 5 to 10 seconds. No convulsive movements occur during the episodes, but her eyelids appear to flutter. She is fully alert afterward. TDK's school performance is somewhat below average, despite an intelligence quotient, abbreviated as IQ, of 125. An EEG shows 3 Hz spike and wave activity. Typical childhood absence epilepsy is diagnosed. Physical examination and laboratory evaluation findings are normal, and no other positive findings are evident on the neurologic examination. So my question to you reads, what drug should be prescribed for TDK, and how should therapy with this drug be initiated? Ethosuximide, valproate, and lamotrigine are commonly used to treat absence epilepsy in the United States. Ethosuximide is a succinimide agent that blocks T-type calcium currents in the thalamus. The drug is effective against absence seizures, but is ineffective against other seizure types. Patients who receive ethosuximide, predominantly children, generally tolerate the drug well and, given its lack of idiosyncratic hepatic toxicity, it has historically been preferred over valproate by many prescribers for the treatment of childhood absence epilepsy. Valproate, a carboxylic acid derivative with broad-spectrum activity against many focal onset and generalized onset seizure types, is highly effective but is associated with adverse effects, dose-related, non-dose-related, and severe idiosyncratic, that limits the drug's use among some patient groups. In addition to ethosuximide and valproate, lamotrigine also has been recommended as an initial monotherapy agent for treatment of absence epilepsy, although it is not FDA approved for this indication. Valproate, ethosuximide, and lamotrigine were directly compared for efficacy in the treatment of newly diagnosed childhood absence epilepsy. Efficacy rates for valproate and ethosuximide, based on freedom from treatment failure, were not significantly different, but were significantly higher than for lamotrigine. Attentional dysfunction was significantly more common with valproate than with ethosuximide. Valproate was also more efficacious than lamotrigine for treatment of idiopathic generalized seizures, including absence, in the standard and new antiepileptic drugs, abbreviated as SANAD, trial. Most authorities now consider ethosuximide the drug of first choice for treatment of absence seizures. Valproate is more likely to cause significant nausea and initial drowsiness, and it is more likely to interact with other drugs, including antiepileptic drugs. Valproate usually is reserved for patients whose absence seizures do not respond to ethosuximide. Clonazepam, a benzodiazepine, often is effective for control of absence seizures. Therapy with this drug is limited by prominent CNS side effects, sedation, ataxia, and mood changes, and development of tolerance to its antiepileptic effect after long-term use. Most authorities consider clonazepam a fourth-choice drug for treatment of absence seizures. TDK should be started on ethosuximide at a dosage of 15 to 20 mg per kilogram per day or 250 mg twice daily. The daily dose can be increased by 250 mg every 10 to 14 days as necessary to control seizures. Because the average half-life of ethosuximide in children is approximately 30 hours, a delay of 10 to 14 days between dosage increments allows approximately 7 days for achievement of steady state and 7 days for assessment of response. We will now discuss patient or caregiver education. Educating TDK and her parents regarding the importance of regular drug administration is extremely helpful in ensuring successful therapy. Non-adherence is common in patients taking anti-epileptic drugs, and rapid discontinuation of these drugs, often secondary to non-adherence, may precipitate status epilepticus. The concept that medication controls rather than cures the seizure disorder should be strongly reinforced. It is also critical to inform both the parents and TDK that a therapeutic response may not occur immediately and that dosage adjustments may be necessary. My next question to you reads: what subjective or objective clinical data should be monitored in TDK for evidence of ethosuximide's therapeutic and adverse effects? TDK's seizure frequency and any side effects she experiences are the primary monitoring parameters. If ethosuximide serum concentrations are used to assist in dosing, 40 to 100 micrograms per milliliter is the usual target range. However, a clearly defined toxicity syndrome does not reliably develop when ethosuximide serum concentrations exceed 100 micrograms per milliliter. Gradual and cautious increases in ethosuximide dosage when serum concentrations are beyond the upper limits of the usual therapeutic range may improve response in resistant patients. Although ethosuximide traditionally is administered in divided doses, its long half-life allows successful use of single daily doses for many patients. Clinicians should be alert to acute side effects of nausea and vomiting that are associated with large single doses of ethosuximide. Should these occur, divided daily doses may be necessary. Laboratory monitoring for idiosyncratic hematologic toxicity from ethosuximide often is recommended. Ethosuximide causes neutropenia in approximately 7% of patients. Although this reaction often is transient, even if the drug is continued, rare patients may exhibit fatal pancytopenia. Presumably, early detection of neutropenia by means of periodic CBC will allow discontinuation of the drug and potential reversal of this adverse effect. These hematologic reactions, however, can occur unpredictably at any time during therapy and often are missed by routine laboratory monitoring. Patient or caregiver education regarding signs and symptoms associated with leukopenia and pancytopenia, e.g., sudden onset of severe sore throat with oral lesions, easy bruisability, increased bleeding tendency, and instructions to consult the physician if these symptoms occur may be more important than laboratory monitoring. TDK's parents should be informed that nausea or sedation may occur with initiation of ethosuximide. Tolerance to these effects usually develops, although temporary dose reductions may be necessary. 3 months later, TDK's absence seizures have been reduced to a frequency of 1 every 2 weeks with an ethosuximide dosage of 750 mg per day. Her initial drowsiness has almost disappeared, and nausea was alleviated by administering doses with food. She has, however, experienced 2 tonic-clonic convulsions in the past month. Both seizures were witnessed by her parents and were well described. No auras or signs of focal seizure activity were apparent, and each episode consisted of typical tonic-clonic activity lasting 1 to 2 minutes. TDK was incontinent of urine on both occasions, and postictal confusion and drowsiness were significant. Physical examination and laboratory testing showed no abnormalities. A repeat EEG continued to show infrequent 3 Hz spike and wave discharges. No abnormal focal discharges were noted. So my question to you reads: what is the relationship between TDK's tonic-clonic seizures and ethosuximide therapy? It is commonly believed, and often stated in the literature, that ethosuximide may precipitate or worsen tonic-clonic seizures. However, this effect has not been clearly demonstrated. As many as 50% of patients who initially present with absence seizures also experience tonic-clonic seizures. Historically, it had been common practice to add another anti-epileptic drug, e.g., phenobarbital or phenytoin, to ethosuximide therapy to prevent this. However, routine use of drugs for prophylaxis of tonic-clonic seizures may increase the risk of toxicity and potentially reduce adherence with medication regimens. Sedative drugs, especially phenobarbital, actually may aggravate absence seizures in some patients. In summary, subsequent generalized tonic-clonic seizures are common in patients who initially experience absence spells. It is unlikely that anti-epileptic drug played a causative role for this development in TDK. My next question to you reads: what alterations are indicated in TDK's drug therapy because of the appearance of generalized tonic-clonic seizures? Drug therapy for prevention of further tonic-clonic seizures is indicated. Phenytoin, carbamazepine, or valproate might be considered for use in TDK. Owing to her age and sex, many clinicians would avoid using phenytoin because of its dysmorphic and cosmetic side effects. Carbamazepine is widely used for secondarily generalized tonic-clonic seizures and some cases of tonic-clonic seizures in children. It lacks many of the troublesome, common side effects associated with phenytoin. Carbamazepine, however, is not effective for control of absence seizures. Therefore, it is likely that both ethosuximide and carbamazepine would be needed by TDK. Carbamazepine also has been associated with exacerbation of seizures, including atonic, myoclonic, and absence seizures, in children with mixed seizure disorders who exhibit bilaterally synchronous 2.5 to 3 Hz discharges on the EEG. The need for polytherapy and the possible risk of seizure exacerbation make carbamazepine a less attractive treatment option for TDK. Valproate is effective for controlling both absence and primary generalized tonic-clonic seizures. TDK appears to have primary generalized tonic-clonic convulsions. Focal signs, e.g., unilateral or single limb involvement, were not observed, and focal discharges, e.g., isolated abnormal electrical activity localized to one portion of the brain, were not found on the EEG. Although neither observation completely rules out secondarily generalized tonic-clonic seizures, the likelihood seems low. Therefore, valproate may offer advantages over carbamazepine in terms of efficacy. In addition, both of TDK's seizure types potentially could be controlled with a single medication. TDK's physician elects to use valproate. The therapeutic goal is control of her seizures with valproate alone. What procedure should be followed regarding discontinuation of ethosuximide and initiation of valproate? Techniques used by clinicians to substitute one anti-epileptic drug for another depend largely on experience and judgment. Generally, it is best to attain a potentially therapeutic dose of a new medication before attempting to discontinue the previous drug. Serum concentration monitoring may be helpful for some anti-epileptic drugs. Ethosuximide has a relatively long half-life, whereas valproate's half-life is short. Therefore, if necessary, steady-state serum concentrations of valproate can be established and evaluated rapidly. Evaluation of the effect of decreases in the ethosuximide dosage must await the prolonged elimination of this drug. Once a desired valproate dose or serum concentration has been achieved, the ethosuximide dosage can be reduced gradually by 250 mg per day every 2 to 4 weeks. Valproate should be initiated at 125 to 250 mg twice daily. Valproic acid syrup or capsules or divalproix sodium can be used. Divalproix often is preferred because it may cause fewer gastrointestinal side effects than valproic acid. Syrup forms of valproate probably should be avoided unless extremely small doses are required, e.g., infants, or patients cannot swallow. Valproate syrup has an unpleasant taste, and its rapid absorption increases the likelihood of acute, dose-related side effects such as nausea. Lower initial valproate doses are less likely to cause acute side effects, e.g., drowsiness and gastrointestinal upset. Weekly dosage increases of 5 to 10 mg per kilogram per day usually are well tolerated and would be appropriate for TDK. More rapid increases may be desirable if tonic-clonic seizures occur frequently. The maximal recommended dosage of valproate is 60 mg per kilogram per day. Many patients, especially those receiving enzyme-inducing drugs, require higher than recommended doses to achieve adequate clinical effect. Other patients may respond at much lower doses. Valproate can be titrated in TDK to produce a target serum concentration of approximately 75 micrograms per milliliter. Because ethosuximide is withdrawn, the valproate dose can be further adjusted on the basis of seizure frequency and side effects. TDK has been taking valproic acid capsules, 250 mg thrice daily, for 3 weeks. Ethosuximide was discontinued 2 weeks ago. At that time, a valproate serum level just before her morning dose was 68 micrograms per milliliter. She has not experienced generalized tonic-clonic seizures for 6 weeks, but continues to have an absence seizure every 2 to 3 weeks. TDK complains of nausea, epigastric burning pain, and occasional vomiting lasting approximately 1 hour after her doses of valproate. All recent laboratory tests were within normal limits. Administration of the drug with meals is only partially helpful. So my question to you reads: what alterations can be made in TDK's dosing regimen to relieve these symptoms and possibly improve seizure control? TDK appears to be a candidate for the use of an enteric-coated valproate preparation or extended-release devalproex. Devalproex tablets are available as an enteric-coated delayed-release preparation, which causes delayed rather than extended absorption of valproate. Therefore, these tablets are not a sustained-release product formulation. When patients are switched from non-enteric-coated formulations to devalproex tablets, the frequency of administration should not be decreased. Valproic acid and enteric-coated dosage forms of valproic acid or devalproex are completely absorbed. These can be interconverted at the same total daily dose of medication. An extended-release formulation of devalproex sodium is also available that can be administered as a single daily dose. Extended-release devalproex, that is devalproex ER, however, is not bioequivalent to other dosage forms of valproate. When equal doses are administered, the ER formulation produces serum concentrations that are approximately 89% of those produced by other valproate dosage forms. Accordingly, when patients are converted to devalproex ER from other forms of valproate, the manufacturer recommends an increase of 8% to 20% in the administered dose. TDK's valproic acid capsules can be replaced with an equal daily dose of devalproex tablets. Devalproex should be administered on a 3 times daily dosing schedule. Alternatively, TDK could be given 1000 mg of devalproex ER once daily. The results of this change should be apparent within approximately 1 week. By that time, significant relief from GI side effects should have occurred. It may then be possible to increase the dose of devalproex in an effort to improve seizure control. Capsules containing enteric-coated beads of devalproex also are available. The 125 mg capsule contents can be dispersed in food for administration to children or others who have difficulty swallowing tablets or capsules. In addition, use of the cap end of the capsule to measure half of the contents can approximate doses of 62.5 mg. 2 weeks later, TDK returns for follow-up. Her gastrointestinal symptoms have resolved. She has been taking devalproex tablets 250 mg with breakfast and lunch and 375 mg with a bedtime snack for the past week. She has had no seizures in the past 2 weeks and complains of no side effects. A valproate serum level before her morning dose today was 117 micrograms per milliliter, considerably higher than her previous valproate level of 68 micrograms per milliliter. The laboratory reports that duplicate determinations of this level agreed within 5 micrograms per milliliter. TDK denies taking her medication incorrectly. Her parents support this, and the tablet count in her prescription bottle is correct. She has taken no other drugs except a multivitamin. How can this disproportionate increase in her valproate serum concentration be explained, and what is its clinical significance? So my question to you is, does valproate exhibit dose-dependent pharmacokinetics? The observed changes in TDK's valproate serum concentrations are probably not the result of dose-dependent metabolism as is seen with phenytoin. Instead, these changes are more readily explained by the absorption characteristics of valproate tablets. Peak serum concentrations of valproate after administration of valproate may be delayed for 3 to 8 hours, and administration of food may further delay absorption. In addition, diurnal fluctuation in both the rate and extent of absorption of valproate may be significant. Absorption may be reduced by approximately 1/3 and peak plasma concentrations may be delayed for up to 12 hours for valproate doses administered in the evening. 12 to 15 hours probably elapsed between the administration of TDK's last dose and blood sampling. Therefore, the currently reported blood level may more closely approximate a peak concentration. Previous blood levels, determined while she was receiving rapidly absorbed valproic acid capsules, are more likely to have been trough concentrations. TDK's adherence to her prescribed dosage regimen also may have increased because of the change in dosage form and reduced side effects. Her previous serum concentrations may not have reflected administration of the prescribed dose. Other pharmacokinetic factors may have actually moderated this unusual increase in valproate concentrations. Valproate concentrations may fluctuate throughout the day in a pattern that does not reflect the timing of doses. This fluctuation may be partially related to changes in serum concentrations of endogenous fatty acids that displace valproate from protein-binding sites. Valproate's hepatic clearance is restrictive, i.e., valproate has a low extraction ratio and its clearance is limited by the free fraction of drug in plasma. Therefore, when protein-binding displacement occurs, free fraction of drug in plasma and clearance increase. As a result, free serum concentrations of valproate increase only transiently, whereas total serum concentrations decrease persistently. Valproate also exhibits dose dependency in its binding to serum proteins. As concentrations approach 70 to 80 micrograms per milliliter, binding sites on albumin molecules become saturated, and the free fraction of drug in plasma increases. This effect also increases valproate clearance and reduces total serum concentrations. Both of these effects may actually dampen the apparent increase in plasma concentrations seen in TDK, when also considering the poorly established therapeutic range for this drug. It becomes apparent that monitoring serum concentrations is a less useful tool in valproate therapy than with some other anti-epileptic drugs. The clinical significance of TDK's elevated valproate serum concentrations is minimal. She is not experiencing symptoms suggestive of valproate toxicity, and it is too soon after the dosage increase to assess the effect of this change on her seizure frequency. Therefore, alteration in her drug therapy is unnecessary at present and might only confuse evaluation of her response to this drug. She should be observed for an additional 4 to 6 weeks to evaluate seizure frequency before further alterations in her dosing regimen are considered. Further increases in her dosage are not contraindicated as long as she is tolerating the medication, and such increases are justified on the basis of seizure frequency. 2 months later, TDK is taking 375 mg of valproate thrice daily with meals. She has had no absence seizures for 5 weeks and no generalized tonic-clonic seizures for 10 weeks. Yesterday, her valproate plasma concentration was 132 micrograms per milliliter. In addition, her alanine aminotransferase, abbreviated as ALT, was 32 international units per milliliter, and her aspartate aminotransferase, abbreviated as AST, was 41 international units per milliliter. All other laboratory tests, that is bilirubin, alkaline phosphates, lactate dehydrogenase, prothrombin time, and serum albumin, were normal. TDK's LFTs have been monitored monthly since she began taking valproate, and they were previously normal. Physical examination was negative for scleral icterus, abdominal pain, or other signs of liver disease. I would now like you to discuss these laboratory abnormalities and physical findings in relation to possible valproate-induced hepatotoxicity in TDK. Liver damage related to valproate therapy appears to be caused by accumulation of hepatotoxic metabolites of valproate, probably 4N-valproate, in certain patients. These metabolites may be formed in larger quantities in patients who also receive enzyme-inducing drugs such as phenobarbital. Most cases of fatal hepatotoxicity have occurred in young, that is below 2 years of age, patients with neurologic and metabolic abnormalities, who also had severe, difficult-to-control seizures and who were taking multiple anti-epileptic drugs. It is important to recognize, however, that severe hepatotoxicity is not limited to this population. Liver damage occurs early in therapy and symptomatically resembles fulminant hepatitis with hepatic failure. Patients may experience vomiting, drowsiness, lethargy, anorexia, edema, and jaundice. These symptoms often precede laboratory evidence of hepatic damage. Liver biopsies in affected patients show evidence of hepatic necrosis and steatosis. Death results from hepatic failure or a Reye-like syndrome. Asymptomatic elevations in liver enzymes, such as those found in TDK, occur commonly during the first 6 months of treatment with valproate and usually are not associated with severe or potentially fatal valproate-induced hepatotoxicity. These changes in aminotransferase usually disappear without alteration in therapy. In some cases, temporary dosage reduction is followed by normalization of laboratory tests within 4 to 6 weeks. Without systemic symptoms or other signs of significant liver damage, it is unlikely that the laboratory abnormalities observed in TDK represent severe liver toxicity from valproate. Because TDK is responding well to valproate therapy, no change in therapy is warranted at this time. Laboratory testing probably can be repeated in 4 to 6 weeks. TDK and her family should be educated regarding the possible signs and symptoms of valproate-induced liver damage and instructed to consult their physician if these symptoms are noted. My next question to you reads: what is the usefulness of routinely monitoring LFTs in patients receiving valproate? Serious hepatotoxicity related to valproate therapy is extremely rare. Historically, the rate of fatal hepatotoxicity decreased significantly. Despite substantial increases in the use of valproate, after the use of the drug in high-risk patients, e.g., the very young, decreased and its use as monotherapy increased. Hepatotoxicity is estimated to occur in less than 0.002% of patients treated with valproate. In children younger than 2 years of age who receive anti-epileptic drug polytherapy, the incidence of this complication is 1 in 500 to 1 in 800. Because asymptomatic, apparently benign elevations in liver enzymes are common early in therapy with valproate and symptoms of liver damage often precede laboratory changes, frequent LFTs during early valproate therapy are unlikely to detect serious hepatotoxicity. Education of caregivers or patients regarding potential symptoms of hepatotoxicity, with careful observation and follow-up by healthcare professionals, is recommended as the most effective method to monitor for this drug-induced illness. In predisposed patients, i.e., very young children with associated neurologic abnormalities and those receiving polytherapy, significant increases in LFT values that are noted early in therapy may be clinically significant. At the onset of symptoms suggesting this condition, laboratory testing may help confirm its presence. So there you have it. Our highly esteemed viewers and listeners, that brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. On behalf of our senior colleague, Dr. Nath Arua, I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 392.